Hello, and welcome to the JASN podcast, where we highlight an interesting recent paper from the journal. I'm Dr. David Ellison, professor of medicine and chemical physiology and biochemistry at Oregon Health and Science University, and a deputy editor at the journal. I'm joined today by Dr. Martin Prince from Weill Cornell Medical Center, who's coming to us from snowy and chilly New York to discuss the paper entitled Automatically Measuring Kidney, Liver, and Cyst Volumes in Autosomal Dominant Polycystic Kidney Disease, which appears in this month's issue of JASN. Dr. Prince, please introduce yourself and tell us a little bit about your background.
Yes, it's a great pleasure to be here. Thank you, Dr. Ellison. I'm a body radiologist, and I've been really focusing on MRI technology. I came to New York City about 25 years ago, and when I arrived, I came across a team of nephrologists who were beginning to study polycystic kidney disease. They were setting up a repository, and they needed somebody who would be able to measure kidney volumes, count the cysts, and just be a little bit more quantitative than the normal radiological approach at that time. And I volunteered for that, thinking that I would be one of many, but I soon learned that this was really hard work and nobody else wanted to do it. I was just doing so many polycystic kidney disease cases. Very quickly, I became really expert and I started noticing things that previously had been overlooked in the radiological world, things like splenomegaly and pancreatic cysts and dural ectasia and pleural and pericardial effusions, and I started writing papers. And so over the years, this has been really a favorite area of me for investigation.
Great, and in some ways you've answered some of the early questions already because we know how you got involved in this. As you note, ADPKD is an extremely common genetic form of kidney disease, and I'm sure that most of our listeners are well aware of both the disease process as well as the limited forms of treatment that are currently available. Perhaps you could start by discussing a little bit more about how you became interested in the disease. I guess you've already summarized some of that, but the disease and developed it as a research focus. It sounds like you really were enlisted by nephrology colleagues coming
Yeah,
from a radiologic background.
it's a great question because in the radiology world where I'm living, I need to respond to what the referring physicians want. And I've discovered nephrologists are very quantitative people. And unlike the average referring physician, they love numbers. And radiology is a very qualitative specialty. So actually, it's hard for them to find someone who's willing to be quantitative. But I went to MIT and I've been always a quantitative person. So this was really fantastic for me to get involved in more measuring things and looking at quantitative details. And wow, polycystic kidney disease has really been overlooked over the years and is now kind of having a resurgence of scientific interest. So, so yeah, this has been a great area for me to get interested in and to be working on.
Well, that leads right into my next question, which is that kidney size has been used for many years to determine progression of ADPKD, and you note in the paper that kidney size or cyst size, kidney size and cyst size was used to obtain approval for tolvaptan for its treatment. You note that the traditional models to estimate volume use, for example, a modified ellipsoid formula, but you say these are all subject to inter-reader variability. You say that manual contouring is more accurate, but tedious and time consuming, and that's maybe why you spent so long performing these studies in the past. So you wanted to see if machine learning could help with this. Were you mostly interested in using machine learning to be more accurate, to be faster, or both?
Well, I'll tell you what happened. Of course, like you know, the modified ellipsoid formula has so much observer variability. Like one radiologist and the next it's like 15 to 18% inter-observer variability, which is a terrible degree of uncertainty when kidneys are only growing about 5% per year. So you got to follow someone for 3 years before you're going to get a meaningful measurement. We wanted to get more accurate measurements, so immediately we took to the manual contouring, which was such an enormous amount of work in these patients who often had gigantic kidneys. Every slice has to be painted, and I had many fellows who would be agonizing over that. Well, when deep learning came along, we really were excited that it maybe could automate this process. Incredibly, I had a fellow who had a degree in computer science, and he knew how to do this deep learning stuff. And he got us collecting the contours for training data and starting to build models. And he took off and got a job at Google Health, even though he's a radiologist. But we've just been building on that, making our model better and better. And now we've gotten to the point where it's really fine-tuned and working really well.
Well, you mentioned that measuring cyst size can improve prognostic information, but that cysts outside of the kidney may also be important for the overall cyst assessment of patients. I'm used to hearing about kidney cyst size in terms of prognosis, but are there other approaches in common use that include extrarenal features as part of the prognostic workup?
Well, the fascinating thing about the ADPKD is how many organs are affected. The kidney obviously is the main patient impacting organ, but there are signs of it throughout the body. The liver is really a big area. The liver can get a lot of cysts, especially women can have massive enlargement of the liver. Sometimes the liver is even more affected than the kidneys. So our model is also measuring the liver volume and liver cyst volume. And this has been useful because these patients want to track how rapidly is the liver growing. And some of them are on a trajectory of requiring liver transplantation. We've even had cases where at the time of renal transplantation, the discussion comes up, should we do a combination liver kidney? Because with the trajectory they're on, the liver is going to be a problem. As the liver gets bigger, sometimes the IVC gets pinched. We had a patient who was 8 months pregnant, and she actually worked at the hospital. And she drove into the parking lot, opened the door, plopped onto the ground, couldn't get up. So she used her cell phone and called the emergency room, and they took her straight to the intensive care unit. She had polycystic kidney disease pinching the IVC and went into circulatory collapse. And so now we're looking at the IVC compression on every case, the cysts enlarging left lobe of the liver and left kidney can compress the stomach. So we look at how much space there is for the stomach to expand. And we're adding to the trace org the ability to track how much fat, visceral and subcutaneous fat, and the skeletal muscle index. Because when you look at the patient, they may look big and fat, but a lot of that is cyst. And we need a way to look at, are they losing muscle mass because they can't eat enough from stomach compression? So these are all some of the ways in which we've really expanded what we can get from the abdominal MRI that impacts patient care. And yes, kidney volume, cysts, that's the main thing. But these other things are gradually going to be more and more incorporated into our website and freely available to add to the mix of information to help patient care.
Yeah, that's really interesting, and sort of it brings to my mind the fact that many PKD patients have a variety of symptoms that aren't directly, that I know, related to like their kidney cysts or something.
Yeah,
And
especially pain.
pain,
The
yes.
pain is very hard to localize. I mean, it's very hard to find the cause. And so one of the things I like to do is I like to look tell me the spot where you are having the most pain,
Yeah,
and I'll look right in that spot on the image to see what's underneath their finger.
yeah,
Is there a hemorrhagic cyst, or is there some pushing of something, or something is twisted?
yeah.
Yes, what is going on? Most of the time, we can't figure it out, but every once in a while, you can see something in the image that can match those symptoms.
So I'm going to take you back to sort of first principles in kindergarten for you, but you use the MRI results with ground truth labels that include T2 and T1 weighted measurements. For those like me who can't remember exactly what the difference between the two is, could you explain that and discuss what information each of those approaches or methods provides?
Yeah, that's a great question. I know plenty of radiologists who don't know what T1 and T2 are. I'm going to start with T2 because I think that's a little bit easier to understand. When we're doing the MRI, we're going to give a radio frequency pulse, and that's going to stimulate a pulse of radio frequency signal from the patient. We call that the echo. So we give a pulse and we get this echo, and the echo lasts in some tissues a long time, in some tissues a short time, like cyst, it lasts a long time. That time is what we call T2, how long the signal lasts. So you can imagine I give a pulse and then I wait a little bit and then I listen for the signal. The only thing I'm going to see are the cysts because everything else has faded away. Only those cysts with very long T2 are still putting out signal. This gives us the beautiful image of those simple cysts. Now, T1 is a little more complicated. After I give a pulse, I have to wait for the tissue to recover before I can give another pulse. And that recovery time, we call that T1. I need hundreds of pulses to build up enough signal to get a good image. So if I'm giving the pulses too fast, then the tissue is going to be dark. So cysts take a long time to recover. So on a T1 image, they tend to be dark, whereas parenchyma recovers faster. So that's going to have more signal on a T1 image. And hemorrhagic cyst, all that iron really facilitates recovery. And those are super bright. So those complex cysts are going to light up on the T1 images. So I need my T2 for the simple cysts, the T1 for the complex cysts. Gadolinium also shows up on T1. So if I'm going to look for a tumor, I'll inject gadolinium. That'll light up on the T1. And it's a little bit complicated, but it explains partly why MRI takes so long. We got to get these different pictures to get all the information we need.
So now I think we'll move on to more the gist of the paper. You used 790 participant scans for the training set, but excluded 70 for internal validation. So how did you come up with these numbers? Was this just arbitrary? And how did you decide how many you needed for the internal validation set?
Yeah, great question because we need the internal validation to get a quick first look at how well our model trained and how it's doing. And people have suggested 10%, 20%, 30% of your cases for internal validation. But our paper is really about the external validation. We have cases from our colleagues in Italy, 131, and we have cases from CRISP, and those are older cases from decades ago. We have more recent cases from the PKD RRC, Research Resource Consortium. And those are brand new cases, state-of-the-art imaging technology. So with these different validations, that's like around 30%, 35% of our training data. That's a really kind of at the high end of the amount of data that you would like to get a good assessment of model performance. So we decided for the internal validation to kind of go on the low end so we could maximize the number of cases that are incorporated in the training data for model building. We felt that was the best use of the material that we had. And if you were to see how long it takes to label a case to create training data, those are precious cases. We really don't want to waste anything.
Okay, great. Now I'm going to ask you to explain a sentence from the paper that I frankly struggled to understand. So this is a quote from the paper. The model integrates 3D conventional neural networks with transformer-based components to capture both local and global contexts, improving segmentation performance across diverse imaging modalities and patient populations. So again, can you sort of play that out in simple-minded language that I can understand?
Yeah, this is a lot of complex technology, and of course, convolutional neural networks are a fantastic part of the artificial intelligence technology revolution. Somewhat modeled after the brain and human visual system, and these are really optimized for processing image data. So what's happening here is that your MR image, which is high resolution with lots of shades of gray, goes through these convolutions in which filters are identifying and mapping image features, like, for example, edges and shapes and blurry areas and sharpness, and all of these features, as you go from layer to layer to layer, become that feature information builds up. And at the same time, we reduce the image resolution. And that helps the model to focus in on the feature mapping process. We call that the encoder. And then when we're done with the encoding, we can do the decoding where we bring the image back to the full resolution. But this time, instead of having shades of gray, we're going to map what's kidney and what's liver and what's cyst. So we're like fundamentally changing from, your picture of the person to this segmentation map of the organs, which is incredible, except that we discovered the CNN, convolutional neural network, is really good for local relationships and features that occur over a greater distance, like left versus right kidney. It was really struggling, sometimes calling the right kidney the left kidney and vice versa. Or it might call the spleen the liver. So we put a transformer in between the encoder and decoder. The transformer is newer technology. It's also an incredible technology which has a more global perspective, and it's better able to map features that are more distant. And the other advantage of the transformer is that as we accumulated more and more training data, we had the problem of saturating our checkpoints, and they weren't able to absorb all of the training information. So that transformer also provides additional model parameters for optimization that absorbs that training information more fully. So in this way, it's using this AI technology really optimized for the polycystic kidney challenge of volume measurement. And then another thing that I should mention, of course, is that we're using 3D instead of 2D in order to get one extra dimension of assessment of the relationships of all the various image features. So it's a lot of stuff, and I think we're just at the beginning of this AI revolution, and you're going to be hearing a lot more about these details.
So along those lines, so it sounds like the trace org model is based on an earlier model. So what has improved since then? Is it you had more training data, or that you had better ML, or what's improved mostly?
Yeah, I mean, that's a great question because, when you have a little bit of training data, then you're better off with a 2D model. Some people recommend that you really need a lot of data to get a 3D model working. So as we've accumulated more data and more experience, we've migrated from the 2D to the 3D model. And like I said, we found ways to deal with these right-left kidney swaps, adding the transformer. And we started out just doing kidney, and then we realized, geez, there's more to it. We got we got to do more organs. So we've expanded the number of things we're labeling. We added the liver, then the cysts. Now we're adding even more stuff, fat and muscle and all the other organs. And I think a really big feature that I want to really emphasize is we are seeing more and more nephrologists and patients struggling with, okay, you got that fancy model, but that doesn't do me any good. How are we going to get the volume at my hospital? And so we really took a major plunge, step forward, and put it out on the web. And this way, people can upload their images. We have a anonymization code that runs on your own computer in the browser. So it strips away all the protected health information. The de-identified images pop up into our server, and it runs this and puts out a report. And I think this is a step, an improvement that I'm particularly proud of because I hoping that this is going to empower others to start using this technology the way we're using it.
Yeah, I think that's great, and I think I was going to ask you some more about validation, but I think you've already gone over that. But I do want to follow up one question about the validation methods. Perhaps you could tell us. You talk about certain parameters of validity, and you talk about the dice similarity coefficient. What is a dice similarity coefficient, and what would be a good dice similarity coefficient that you would look for here? I mean, it sounds like the trace-org model performed very well, but can you give us a little context there?
Yeah, that's a great question. DICE is basically it's one of the metrics we use, probably the most important metric, and it's basically measuring what percent of the voxels are correctly labeled. And so if your DICE is 90%, you got 90% of your kidney voxels correctly labeled. And generally in this field, if your dice is in the 90s, that's pretty good. That's viewed as a high performing model. So we're very excited that our dices are coming in out at 97%, 98% range for kidneys and liver. That's really something that we're proud of and happy to be able to report. The cyst dice is lower, kind of low 90s for renal cyst, and it's dipping into the 80s for the liver cyst. And that just reflects the fact that cysts are much more challenging to label and much more challenging for the model to get that label correct. And we don't have as much training data for them. I think as time passes and we're able to get more training data and that's gonna be improving.
Yeah, I want to follow up with probably a last question that I didn't write down, but I've been wondering about this, and I want to ask you specifically. So you make the TraceOrg app, whatever, available online publicly, which is a tremendous thing. I mean, I think that's a great benefit to everybody. If one of our radiologists or someone here was going to use your model, does it absorb the actual images and then do the calculations? How is the data input for somebody who wants to do it, let's say here in Oregon?
Yeah. So what you would do is first of all, you got to download your DICOM images, and then you will make an account which will include your email so that you can get the report. And when you upload your images, you will create a fake name. We call it pseudonym, and that'll be how your images are labeled. Then when you do the upload, all the PHI is stripped away. It goes into our server. The report is created. If, let's say, your MRI had a T1 and a T2 and maybe an SSFP, we will calculate the kidney volume and the liver volume and the cyst volume for all of those different MR pictures, and you can see how well they agree. And if you're getting the same kidney volume on all your sequences, very similar volume, then you know, okay, it's probably pretty good. But if you see like a big discrepancy among the different sequences, then that means you should check and try to figure out what went wrong. Maybe one of the pictures didn't include the whole kidney, or maybe, the model may not be perfect. And in addition to the written report, you can download the actual segmentations and use any of a variety of programs, but we recommend a freeware called ITK Snap as one of the better programs for checking the labels on your images and making any adjustments if you would like to do that. And then it also makes it very easy to see what the new volumes are after you make adjustments. ITK Snap,
Great.
Free software.
Well, it's tremendous. I think I've learned a lot about all of this stuff chatting with you, but I hope that this is a major step forward for both radiologists and nephrologists. Sounds like to get a good assessment of kidney and liver and other organ damage by PKD, and all of which can be downloaded or used through your publicly available app, which is tremendous. So I've really enjoyed chatting with you, enjoyed reading the paper, and good luck in the future improving the model.
Thanks, Dr. Ellison. It's been a pleasure to chat about it. We look forward to introducing more advances.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.